Hi, this is Michael Altos, and we're still talking about psychiatric and CNS drugs, and this is part 2. The next drug we're going to discuss is lithium. Lithium has been the treatment of choice for bipolar disorder, that's manic depressive disorder. One concern with lithium is that we have to measure plasma concentrations very carefully, especially when patients are being started on these drugs, or if they're at risk for a change in their serum levels. Lithium is filtered by the kidney at the proximal tubule, and it actually competes with sodium, another single charge cation. When patients become sodium depleted, say if they're dehydrated or given a diuretic, this may actually increase lithium levels as a result. Side effects of lithium include polydipsia, which is increased thirst, polyuria, and hypothyroidism. Patients taking lithium may show prolonged responses to both depolarizing and non-depolarizing drugs. So we want to be careful when we're administering neuromuscular blocking agents. Neuroleptic drugs, or antipsychotic drugs, given together with lithium may have an increased risk of extrapyramidal side effects and neuroleptic malignant syndrome, which we will discuss a few slides later. Patients who are taking lithium should not be given diuretics, specifically loop and thiazide diuretics, because of its effect on sodium levels, nor should they be given NSAIDs because of the effect on renal blood flow. Patients who have lithium toxicity may show lethargy or weakness, or they may have a tremor or cardiac symptoms like QRS widening or a complete heart block. They may develop hypotension, confusion, and seizures. And again, these are exacerbated in patients who are dehydrated, sodium restricted, and taking diuretics or NSAIDs. If it gets bad enough, severe lithium toxicity may require osmotic diuresis or even dialysis. We will pause here for just a moment before we continue with the lecture. If you have any questions, please let me know. The next set of drugs we're going to discuss are the antipsychotic drugs, also known as neuroleptic agents. These drugs are used to treat schizophrenia, a psychotic disorder, and often also used for bipolar disorder or manic depression. There are many drugs in this category, including chlorpromazine, which is thorazine, clozapine or clozaril, risperidone, which is Risperdal, and what may be most commonly given by you, haloperidol or Haldol. Droperidol is also an antipsychotic drug. These drugs work by blocking dopamine receptors, and they are metabolized in the liver. The most common side effect of the antipsychotics are the extrapyramidal effects. These are all different kinds of movement disorders, and almost all of the neuroleptics can lead to extrapyramidal side effects. In this group of effects are included tardive dyskinesia, which are abnormal and involuntary movements of the face, neck, and tongue, as we can see in this series of pictures over here, or an acute dystonic reaction, which is acute rigidity of the muscles or cramping, and this can occur in the face, neck, tongue, or even larynx, leading to breathing problems. This is usually treated with Benadryl, diphenhydramine, or benztropine cogentin, and this is done actually not for the histamine effects, but for the anticholinergic effect. Patients can also develop Parkinsonism, which is rigidity, tremor, or small movements like bradykinesia or even akinesia, lack of movement at all. Or they may develop akathisia, which is restlessness. Here are some more pictures. This shows someone who looks like they're having an acute dystonic reaction. Here more in the extremities, and here in the eyes and the face. Another side effect of antipsychotics is neuroleptic malignant syndrome. This presents as hyperthermia, muscular hypertonicity, so increased muscle tone, autonomic instability, and mental status changes. Patients may become so rigid they need mechanical ventilation, and they may develop necrosis of their muscles, which would lead to renal injury. The incidence is about 1%, and the mortality can be as much as 20 to 30%. The cause is not exactly known, and as you can see, it looks a lot like malignant hyperthermia. In fact, one of the treatments for NMS is dantrolene to relax the muscles, and then a dopamine agonist, something to counteract the dopamine antagonist, such as amantadine or bromocriptine. In these patients, if you gave them a non-depolarizing neuromuscular blocking agent, like rocuronium, this should cause flaccid paralysis. It should cure the rigidity. Whereas in malignant hyperthermia, as we've learned before, non-depolarizers will have no effect on the rigidity. Other effects of antipsychotics include cardiovascular effects. Patients can have alpha blockade leading to orthostatic hypotension. And very important for you to know about the prolonged QT interval, which can lead to patients developing ventricular tachycardia or torsade. This was the reason that droperidol was taken off the market, because of its risk for prolonged QT interval. Although, as we will see when we discuss antiemetics later, it's probably no more dangerous than other drugs that prolong the QT interval, including haloperidol and Zofran. Antipsychotics have endocrine effects. By blocking inhibition of prolactin, they can lead to galactorrhea or milk production in men and women, as well as gynecomastia. They can decrease release of corticotropin, a stress hormone precursor, leading to decreased corticosteroids. And patients on these drugs may have weight gain and hyperglycemia. In addition to their effect on psychosis, CNS effects include sedation, antiemetic effects, and a dysphoric response, which is an unpleasant emotional response. One drug, clozapine, can cause agranulocytosis, which is a lowering in the granulocytes, the white blood cells, and they may occasionally potentiate the action of opioids. That's the end of this video. We'll continue with the next video, and we'll see you there.